the first question there was about ventilation. What is ventilation versus, airway support? So let me just start with this. When we breathe in, normally our lungs have negative pressure. Our diaphragms descend, and that creates a vacuum, a slight vacuum, and air is pulled in. That's the physiologic way that breathing occurs, negative intrathoracic pressure. If we take a patient who has very poor musculature, can't make their respiratory muscles work, or nerve damage, the most physiologic way to treat them would be in the iron lungs that were heavily used during the era of polio. I believe there's one patient in the world today still living in an iron lung. Maybe there are more. There's one of whom I'm aware. The advent of intubation tubes that go down the throat through the vocal cords into the trachea with a little balloon that blows up right at this level. That allowed us to control breathing very quickly and easily without putting people in this massive room-sized iron lung. We don't really have iron lungs anymore. So when we do that, we blow air in to inflate your lungs, and then we stop blowing air in, and your lungs' natural elasticity blows the air back out.
Got it.
And that is a perfectly normal and healthy way to breathe, except for one thing. It's positive pressure during blowing the air in as opposed to negative pressure during blowing the air in. That has a lot of effects on the heart, the refilling of the heart, the blood flowing back into the thorax from your periphery, from your arms and legs, getting into the heart. Sometimes that's a positive kind of an effect. It can help to unload the heart in a patient with congestive heart failure. If you have less blood flowing in, your heart is less overstretched. Your heart may be able to push blood out into your chest more easily because it's not already full of blood. And so that kind of thing, positive pressure ventilation can be life-saving for those people where negative pressure ventilation really didn't help them that much. Right. But for most people, there is a slight risk that over time we overinflate the lungs, we may injure the lungs in this way. Particularly if one part of the lung is collapsed and the other part is open, the air may not go to the collapsed part, it may go preferentially to the open part. Just like when you blow into a balloon, there's those long, thin balloons that they make at fairs that no normal human being can blow up. You try to blow into there, blow as hard as you can. You cannot get it to start stretching. But once you get it popped open, now you can blow pretty easily because the pre-stretched part expands much more readily, much less tensile strength sort of holding it together. And that can happen in the lungs. So the closed part doesn't get the air, the open part gets overinflated, and you can end up with alveolar injury, lung injury. That is one of the mechanisms by which ventilators, respirators that push air into your lungs can cause harm in patients with this COVID-19 because they do have many areas of the lung that are collapsed, and not just collapsed like an ordinary pneumonia, where maybe it's collapsed and you might like to pop it open and splint it open, then it would be fine. Maybe it was collapsed because it had a little fluid in it or white blood cells in there. Not like that. In this case, we're talking about interstitial, meaning between the cells, thickening. The entire walls of that thing are becoming extremely thick, and they inherently don't have the flexibility at that point that they should have. Now, it's possible they may be gummed down by thick, inspissated mucus that's dried up. I have not seen those autopsy reports. I've heard many reports of that kind. At this moment, in my community, they are regarded as rumors.
Right.
The only autopsies that I've seen have not shown inspissated mucus. And there are special things we can do to treat that mucus, but if it's not there, it won't help us to treat them. So I hope I've answered at least one question. Perhaps I'll stop at this point and let us refocus.